All right, let's talk about tibial plateau fractures. We all know these are a true test of our skills, right? They challenge us on every single level, from getting that perfect anatomic reduction to managing that incredibly delicate soft tissue envelope, all while we're trying to think about the long-term health of the knee. So, in this explainer, we're going to walk through a really clear, systematic approach to help master these complex injuries. So here's our game plan. We're going to start right where it all begins, in the trauma bay, covering that crucial initial assessment. Then we'll dive into imaging and classification, because you have to understand the fracture's personality to treat it. From there, it's all about surgical planning and the nuts and bolts of fixation, before we finally look at the long road ahead, complications, and what a good outcome really looks for the patient. Okay, let's begin at the most critical point, the initial assessment. With these high-energy tibial plateau fractures, what we do in those first few hours can make or break the final outcome. And it all starts with understanding the anatomy of the injury, not just the bone. This gets to the absolute core of managing these injuries. It's so true. The fracture pattern tells us what surgery we need to do. But that soft tissue envelope, well, that's the ultimate gatekeeper. It tells us when we can do it. If you ignore the swelling, the blisters, the massive contusions, and you operate through a compromised envelope, that is a one-way ticket to wound problems and deep infection. So our initial protocol is absolutely non-negotiable. First, it's always ATLS. We have to remember these patients are often polytrauma victims. Next, a meticulous physical exam. Is it open? Are the compartments rock hard? You have to have an incredibly high suspicion for compartment syndrome right from the jump. And then the neurovascular exam. Any difference in pulses demands an angle brachial index, and if that ABI is less than 0.9, you have a vascular emergency on your hands, and an arteriogram is mandatory, period.
All right, so the patient is stabilized. Now our focus can shift to really decoding the injury itself. This is where our imaging and our classification systems become our roadmap, helping us translate this complex, three-dimensional problem into a clear surgical plan.
X-rays are obviously our starting point. AP, lateral, and that 10-degree caudal tilt plateau view are essential. But we have to know their limits. So often they underestimate the injury. The CT scan, though, especially with those 3D reconstructions, that's where the truth comes out. It unmasks the real extent of the articular depression and comminution, and this is critical, it's the only way to reliably see those posterior shear fragments that are so easy to miss on plain films. I love this. This is exactly how we should think about classification. It's not one system versus the other. We use them together. Schatzker gives us the common language, right? It lets us talk to each other about the fracture. But the three-column concept, that gives us the tactical map for our surgical attack. Now, what's really interesting here is how this classification follows a progression of energy. It takes you from the lower energy lateral side injuries, your type 1 splits, your type 2 split depressions, and type 3 pure depressions, and it ramps you up to the higher energy medial bicondylar and those totally dissociated patterns. And each type has totally different implications for stability, for associated injuries, and for your surgical approach. And this is where surgical planning becomes truly three-dimensional. The three-column concept forces us to look past the standard AP view and recognize that posterior aspect of the plateau as its own separate column. Why does that matter? Because those posterior coronal splits need their own dedicated approach and their own fixation. Ignoring that posterior column is probably one of the most common pitfalls in treating these. And this model right here is our best tool to make sure we address the entire injury. It's absolutely vital for restoring stability. Okay, so this brings us right to the strategic heart of this whole discussion, how we actually formulate the surgical plan. For these high-energy, really complex tibial plateau fractures, the whole goal is to impose order on a chaotic injury. We want to turn an emergency into a controlled, staged reconstruction. For these really nasty, high-energy injuries, our strategy is simple, but it is so powerful. We create order through a staged approach that puts the soft tissues first, letting them recover before we go in for definitive fixation. This one thing is the key to minimizing complications. So let's break that down. SPN. We get the patient to the OR for an X-fix. This pulls the limb out to length through ligament ataxis, it restores alignment, and most importantly, it provides stability, which lets those soft tissues just rest. Scan. With the limb now stabilized and out to length, we get our definitive CT scan. Now we have the true, unobscured picture of the fracture. And then, plan. Now we wait. And this is the hardest part. We let the swelling go down, we wait for that wrinkle sign, and only then do we proceed with our definitive, well-planned ORIF. Regardless of the fracture pattern or whatever hardware we choose to use, these 4 goals are our North Star. Yeah, we all strive for that perfect articular reduction, but the data is so clear, restoring joint stability is the single most important predictor of a good outcome. After that comes restoring the mechanical axis and, of course, a constant, unwavering respect for that soft tissue envelope. So let's translate these principles into action. We're going to look at how we match our fixation tactics to specific fracture patterns, and we'll start with the more common lateral-sided injuries. This is a perfect example of how we can approach a classic Schatzker 2. On the left, you see the power of arthroscopy. It lets us directly see and precisely elevate that depressed articular fragment. And the result, on the right, is a beautiful anatomically reduced joint supported by a buttress plate and, crucially, that subchondral raft of screws to make sure it never collapses again. This concept right here is a real game changer for these depression-type injuries. So once we've elevated the articular surface and we've filled that metaphyseal void, usually with bone graft or a substitute, these raft screws create this rigid subchondral scaffold. Think of them like floor joists. They're placed parallel to and just a few millimeters below the joint surface, and they just physically prevent those elevated fragments from sinking back down over time. Now, when we get to the complex bicondylar fractures, the decision-making gets a lot more nuanced. The big question is always about the approach. Do we go with a single large anterolateral incision, or do we opt for dual incisions? And a flowchart like this really helps illustrate that the choice is driven by the fracture pattern itself. More often than not, dual, medial, and lateral incisions are actually safer for that soft tissue bridge between them, and they give you superior access to both columns, especially when you have to tackle a posteromedial fragment. The key takeaway for these severe injuries is really adaptability. Yeah, dual plating is the workhorse, but sometimes a strong lateral locking plate might be all you need if the medial column is a simple, large, reducible fragment. The absolute priority, though, is to identify and directly fix any posterior medial shear component. And I have to say it again, for these high-energy patterns, staging the surgery, it isn't just an option, it is the standard of care. So the surgery might be done, the patient's in recovery, but our job is far from over. Now we get into the phase of navigating the aftermath, where we have to be super vigilant for potential complications and really understand the factors that define a successful, long-term result for our patients. These are the 3 big ones, right? The complications that keep us up at night. Post-traumatic arthritis is by far the most common long-term problem, and its seeds are sown by any leftover instability, malalignment, or if we had to perform a meniscectomy. Infection, well, that's a devastating complication with risk factors we can often mitigate, like surgical timing. And finally, malunion or stiffness can completely undo an otherwise technically perfect surgery, which just highlights how important it is to get fixation that's stable enough for early motion. This slide right here, this is basically our ultimate report card. A good outcome is a knee that is first and foremost stable. It's a limb that's aligned correctly. It's a joint surface that's congruous, with its menisci preserved to act as those crucial shock absorbers. And of course, it's a knee that is healed without the massive setback of a deep infection. If we can hit these targets, we give our patients the absolute best chance of getting back to a high level of function. And this is the question that should really be driving our research and innovation forward. We've become very, very good at the mechanical part of this equation, the carpentry, if you will, achieving stable anatomic fixation. But even with a perfect X-ray, the initial damage to the cartilage and that inflammatory cascade set off by the trauma can still lead to arthritis. So the next great leap forward will almost certainly be in the biological domain, finding new ways to protect the cartilage and modulate the joint's response to the injury right from day one.